I'm going to call this to order. My name is Dr. Avinash Atrikar. I'm the chairperson for this governing board meeting. It's also my first one that I'm chairing, so please bear with me on circumstance and protocol. Do we go around introductions to take a roll call? Is that the way we usually do it? Okay, so I'll start. I already introduced myself.
Todd Winder, Administrator, Fort Baird Medical Center.
Jeff Esquivel with ITSD Application Support for Facilities.
Susie Archuleta, Nurse Administrator, NMDOH.
Francis Tweed, Hospital Administrator, NMDOH.
Michelle Fields, Medical Staff Office.
Tammy Alikar, Administrator, Los Lunas Community Program.
I'm Thomas Arrow, Department of Health.
Dennis Satterfield, ITSD, Region 3.
Chris Bringle, ITSD.
Angela Silvers, Office of the Cabinet Secretary.
Eric Chenier, Legislative Finance Committee.
Jose Barola, Hospital Administrator for New Mexico Rehabilitation Center.
Carmela Sandoval, Administrator for Sequoia Adolescent Treatment Center.
Shauna Hartley, Hospital Administrator, Turquoise Lodge. Roberta Vijay, Facilities Medical Officer.
Melinda Walensky, Office General Counsel.
George Morgan, ASD Deputy Director.
Great, thank you. How many, I assume we have a quorum here, but can somebody tell us what is the official number for a quorum?
It's usually half of
50% of the members.
Okay, so it's a quorum.
Carmela Sandoval, Administrator for Sequoia Adolescent.
Okay, is there anybody else on the phone? No, okay. Next order of business is approval of the agenda. Does everybody have the agenda in front of them? Really quickly here. Is there a motion to approve this agenda?
Motion.
And a second?
Second.
All in favor say aye.
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 Aye. The agenda is approved for this meeting on April 18th. We have a little bit more housekeeping. Approval of minutes of the previous meeting from January 17th of 2019, as well as in your packet, you should see March 6th of 2019, which was an emergency meeting. Is there a motion to approve these previous minutes?
I can make a motion.
Yes, we made the motion. Is there a second?
I'll second.
Second, thank you. All in favor? Say aye.
Aye.
Aye. Minutes are approved from the previous two meetings just described. New business reports, Office of the Secretary. Let's see. Give me one brief minute. Tom Massaro, Dr. Massaro, while it has not, we have not made an official announcement, I'm going to make an official announcement here. Tom Massaro has been hired to be our Chief Medical Officer for the Department of Health. So we wanted to welcome him. He'll be involved in these governing board meetings, as well as our facility meetings and other things that the CMO will likely be doing for these agencies. So welcome, Tom. I don't know. Okay, I think instead of doing an Office of the Secretary report, I did not have one from Secretary Kunkel today. We'll go through facility administrative reports and we'll begin with Turquoise Lodge with Shauna Hartley.
Okay, good morning. My name is Shauna Hartley and I'm the Hospital Administrator at Turquoise Lodge. I'll be presenting our Q3 FY19 Governing Board Report. So at our hospital, we continue with the same service provision lines. We have our 16 medical detox beds, our 16 social rehab beds, We will continue to be the vendor for the county for their MOTU clinic until the end of June. And we continue with our one track of IOP. Some of our service provision highlights this quarter is that we are finally moving our facility to our new Gibson Medical Center location, which I'll talk a bit more about later in the presentation. We have implemented several program enhancements this quarter, and we are in the process right now of actually transitioning our vendorship from the MOTU clinic to UNM. And so myself and my director of nursing have been diligently meeting with the county weekly to discuss that transition, which will happen on June the 30th. Our demographic information as far as how many people we serve has continued to be pretty steady. We serve 6 less people than we did last quarter. Our occupancy rate has maintained itself at 77%, which is 3% less than last quarter, but it's still above national average. Our demographic information as far as our ethnicity has pretty much remained the same. We continue to service pretty much the same consumer. The majority of people that come to our hospital are alcohol dependent, secondly opiate dependent, and we continue to service the majority of our clients tend to be between the ages of 31 and 40. We have seen a bit of an increase in the age range of 21 to 30. This quarter in our MOTU clinic, we saw 314 people. That was less than last quarter, but actually in the springtime that tends to be pretty customary amongst substance abuse programs. It gets warmer, less people are interested in recovery. Things tend to trend in that direction. We will be turning this program over to UNM, so this will be the last time I'll be reporting these numbers for this program. And we've had a very collegial relationship with the county and UNM, and we are really trying to inform them of the product that we've been providing, giving them guidance as to how we've handled new customers, existing individuals, their medication refills and so forth. And I also will make myself available even after the contract is over. In regards to our contracts, not much significant changes from last quarter. One note is that last quarter I was utilizing some temp employees for janitorial services, and this quarter we were able to hire somebody, and so we're no longer using that. Last quarter was the first quarter I had 0 agency nursing costs. We did have to hire an individual that's working a couple of days a week, and so those costs have gone up, but for the most part, since we've had the increase in the nurses' pay, we have been able to hire more nurses that actually are the Department of Health nursing staff. Our financials continue to be pretty much the same. One thing to note is that we do have more of a steady income, I think, every month now. It does appear that the MCOs have really locked in and understanding how to pay us as an IMD status at this point. And so instead of just kind of, big sums of money based on working with the MCOs diligently trying to get paid, it seems like we have gotten to a steady point where everybody, the MCOs systems are configured. They honor the 99226 number that we're utilizing. And that has a lot to do with myself and my finance department and Roberta Vigil, who's here to my right, really working hard with them to collect our revenues. One highlight I wanted to note was myself and my finance director were looking at our revenue collections from our guarantors from 14 to 19. And we've made some pretty significant gains in FY14. Turquoise Lodge Hospital basically collected $957,000, and in this quarter, and we still have 3 months to go, we're at $1.9 million. I contribute this to a lot of different factors. One is that in 2014, we started really looking at creating a utilization review department, which is very similar to the private sector, where you have someone really working your claims, your denials, interfacing with the insurance companies solely. We also increased the patients in our hospital. And so basically our census, we had about a 500% increase, somewhere between 15 and 17. And that was due to just basically enhancing our access system and getting people in quicker, turning our beds over faster, and just being more diligent in that area. I also contribute this increase to just individuals' eligibility for insurance, increased collaboration between my utilization department and my billing department. And we put in a whole new process where we're sitting down with the medical staff and nursing staff, and we're reviewing documentation that they're doing every month, and any denials, we're sitting down, we're doing education around that to improve our documentation to make sure that we get reimbursed. Our TLH program enhancements this quarter is that we were very fortunate enough to hire a new medical director, and her name is Dr. Pate. She's actually board certified in internal medicine and addiction medicine. She comes from us from Presbyterian Hospital. She has been working with us part-time for the last 90 days, and actually Monday she's going to be starting with us full-time. We also have joined with Bernalillo County, where we have been able to get actually free kits of Narcan. And so this next week, we're actually starting to do training with the nursing staff, with the medical providers, and every individual who's been identified as opiate dependent at admission in our hospital is going to leave with 2 free kits of Narcan and understand how to use those. I have also completed our application to become a peer support pre-exposure our site. And what that means is that basically individuals who are peer supports in New Mexico can actually come to our hospital for 40 hours and complete their internship hours. And so I think that that's going to be a huge program enhancement for us. We've also joined with new Metro Court collaboration, where we're actually going to start getting reimbursed for some individuals who are associated with the court system, who are court ordered to go through a social rehab program. And in the spirit of moving our facility, we're also becoming a tobacco-free facility in about 3 weeks, which has been a huge endeavor, which I'll talk a little bit more about on my next slide. So we are moving our hospital, and I'll talk about that here in a little bit. And we have been existing at a facility where individuals are able to smoke. We're actually going to be moving to Gibson Medical Center in June, and that facility actually allows their consumers to smoke, but we as a facility have decided that we want to go non-smoking, and we're doing this very feverishly and very fast. It's the best thing to do, I think, in the spirit of moving to our new place. And so in the last month, we have a committee together. I've been surveying the patients. We've been notifying all my staff, training them on the new medication orders for tobacco cessation. And basically, we have a set date of May 20th, because we're going to go non-smoking 30 days before we actually move. So wish us luck. On the next slide, this is our moving schedule. I've been talking about moving our facility for about a year now. We were slated to move in December, then in March, construction, different things kind of got in the way of that. But basically, we have a pretty set agenda now. The plan for our move is that the last week of May is when DHI and the fire marshal is going to come in, and they're going to basically give us our certificates to occupy the facility. We will be preparing the facility the last week of May, utilizing some of Carmela's staff and Tammy's staff, so I'm very appreciative of that, helping us get ready to basically occupy the facility. We're going to have 4 different moves. Prior to the moves, I'm going to have several field trips for my staff where they can actually go see the facility, walk them around, not only the facility that we're going to be occupying, but also the hospital that they now are going to be working at. On June 13th, we have our first move. That's going to be medical records in their finance department. On June 14th, I'm moving the administration offices and all the counseling offices. The counseling staff will continue to obviously conduct groups at the old facility, but we're basically going to be moving, their offices and the majority of their belongings. On the 17th, we're moving the pharmacy surplus and all equipment areas. And on June the 19th, we're actually going to be moving all the detox patients, all the rehab patients, and our entire nursing staff. So next time we meet for our next governing board will be in our new facility. And of course, the last week of June, we're going to be preparing the Zuni facility for our final walkthrough. With our HR, we actually haven't done a lot of hiring this quarter, and partly that is around space. As I've given notice from my landlord, they're obviously making plans for their new facility at the Zuni location. And so we really had to slow things down because we really just don't have any offices to utilize. We're in a pretty small space right now operating. And so we've had to not necessarily put that on hold, but just kind of slow down that piece simply because I don't have places for folks to be. New big hires this quarter was obviously our medical director. I also hired a HIM director and I hired one counselor. And that's Lonnie and I, my safety director, with our hard hats on. And I don't know if you guys have any questions.
Are there any questions? Any questions from the phone? I have one question. So the tobacco-free component, is that for staff and clients?
Yes, it is.
So that's going to be very, very difficult to implement in drug treatment. Good luck to you.
Thank you.
Well, I think we'll probably need that, whatever you learn on how to implement it in some of our other facilities. Any other questions or comments?
Yeah, I
Yes.
have one actually on the billing. Your billing now is in IMD status. That's as a result of the Centennial Care 2.0 changes.
That's in result to us not being accredited.
So now you're accredited?
No, we're not accredited, but that's how we are being paid because we're not accredited. So I'm being covered under the IMD status for my medical detox program, not social rehab at this point because we're not accredited. And so that's what we did to cover ourselves based on not being accredited.
Okay. Any other questions or comments? Thanks. Let's move on to Fort Bayard Medical Center, and Todd Winder will present.
Thank you. This is our Fort Bayard Medical Center report for the third quarter of fiscal year 2019. Our first slide there again just goes over our services we're providing. The skilled rehab and extended care, that is a 70-bed unit. Our dementia care is a 90-bed unit, and then our veterans unit is 40 beds. This next slide is our status of our surveys. We are in our survey window, as you can see from the dates there. We have not had any complaint surveys in any of the areas since our last survey. One thing I forgot to put on here was we did have our visit from the Board of Nursing for our CNA program. We did very well there. The only recommendation was that we label and date the water on the med cards. So, no water to go back. This shows from our utilization through the quarter. Inpatient days, 11,670. We had 20 admissions and 24 discharges during this time period. Utilization again continuing. Our average daily census for the quarter was 129.68, with their percent of beds occupied of 107. Our finances, I'm not sure why the numbers didn't show up here. Again, we're staying pretty consistent. You can see there. This reflects our indigent services. For the third quarter, our indigent services were 699,000, just over 699,000, which reflects 13.3% of our revenues. Our collections for the quarter was at 95.5. The year-to-date is 87.3. We now have a few temporary staff in our billing collections department, which is making it a large difference. We're hoping we can get that back up to into the 90s on the year to date before the end of the fiscal year. Human resources, we currently are staffed at 244 and a half FTEs. Our turnover for the quarter was 1.5%, with it being 2% year to date. At the end of March, our vacancies in direct care were 48.5 or 27.4%. Our indirect care was at 21.5 FTEs or at 16.24% for a total vacancy of 70 positions, which amounts to about 22.7% vacancy. I can say within the last week we have brought on 3 new RNs, so we're excited about that. Started on Monday. Here's some clinical information. Our actual hours per patient day were at 3.98. Our acuity was at 3.08, and again, that reflects the bed availability of 107%. In our infection control area, we had a total of 84 infections. That was up this quarter. The AGI infection rate was 94%, and we had 9 identified multi-resistant organisms. Some of those infections. Then in staff development, we're still working with our staff on the CMS requirements as we approach the end of phase 2 and beginning of phase 3. We're also working on clinical competencies, customer service, and employee performance. Are there any questions?
Are there any questions from those that are here? Those on the phone, any comments? I have one question. Am I going to be the only one asking questions? That's my first question. And my second question is, your slide, you're over 100% of your available beds. I saw that, right? So that has to do with nursing and the number of beds that you have available. So you're.
So what that is reflecting is the number based on our nursing and our target hours per patient day.
Correct.
How many patients? We're actually 107% above what our staffing was for the quarter.
Correct. It does make sense. But it also tells me that physical capacity, there's probably 70 beds available. Just the beds. Not staffing for those beds, but beds available.
That's
right?
right. That's
I
right.
just wanted to know that. Thank you. And then my last question has to do with CMS required training. And where, how far along are you with that process?
In what respect?
Do we have a we need to make a plan for probably all of our facilities, right? We're going to have to talk about CMS required training moving up in the future. When does that due in November?
The new requirements take effect in November. Okay. The specific training requirements. But we always train on any aspect of the regulations at any time.
Okay.
But there are some new required in November.
Okay.
That'll take effect.
Great. Thank you. Any other questions? All right. I think we're ready to move on to New Mexico Rehabilitation Center with Jose Corolla, please.
Hello, I'm Jose Corolla, Hospital Administrator for New Mexico Rehabilitation Center. Our facility continues to provide the 4 service provisions on our 2 separate units. On our inpatient medical rehab unit, we continue to provide that intensive one-on-one therapy and medical care for the patients within the state who've had strokes, the traumatic brain injuries, motor vehicle accidents, and spinal cord injuries. We just recently received our passing compliance this week to our 60% rule for admissions of patient populations meeting that 1 of 13 diagnosis medical condition criteria. And that was approved through our CMS, federal CMS independent rehab facility criteria this week. Our chemical dependency unit consists of 3 distinct levels of care for patients who are seeking that variety treatment for substance use disorders. We've got 8 medical detox beds, in which we're treating alcohol, opioids, benzos, cocaine, and meth, just to name a few. The type of care, ASAM care that we are following is 3.7 withdrawal management, just medically monitored type care. It's still directed 24/7 by the medical team, along with counselors who offer the education, the programming, readiness to change assessments for the next levels of care. Our 28-day residential treatment program, again, focuses on multiple substance use disorders as well, but it's primarily for those adults who are exploring that extended recovery, the options and sustainment for sobriety of their substance use. ASAM criteria that we follow on that unit is 3.5 medically monitored. So the counseling team, the team who primarily engages the patients in this 28-day stay to individually address the treatment plan, any goals, emotional, cognitive regulations, and triggers that lead to reactive states. In our intensive outpatient program, we continue servicing individuals who are willing to participate, who have gone through the detox as well as that 28-day residential stay, and also those within the community. Yeah, that's the site. And those within the community who are reaching out, who need more structure and more support, who can come into a facility to receive individual counseling as well as group counseling there. We follow an evidence-based treatment model, IDDT, in our education, our programming, which of course has that component to address any co-occurring disorders such as behavioral health. So first off, quarterly census statistics for our inpatient rehab unit, our medical inpatient rehab. The census remains closely consistent with our previous years. We serviced 28 patients this quarter for 102 the past 9 months. It is slightly above last year. Our total patient days remain the same as last quarterly numbers. We did have an increase, we noticed, in our number of ortho rehab patients versus our stroke and traumatic brain injury patients this quarter. We had a total of about 40 patient referrals that did not admit to our unit. Reasons being the patients either requested to be moved to a skilled nursing facility, they were transferred to a higher level of care after a referral was made to our facility, or there's other rehab hospitals within a close proximity of the large city or joint ventures. Our case mix index is still below the regional national standards in comparison. However, I think our continuous challenge here is providing the safety net services to service indigent, of course, non-funded and undocumented type care. That increases our length of stay efficiency due to difficulty finding resources upon disposition. But however, I would like to positively point out that we're still the only freestanding rehab within the state that offers this type of medical care for patients. So that's a huge plus. We 23 patients that were discharged, out of the 23 that were discharged back to the community. That's our primary goal. We had one that transferred to a local hospital with complications, and that was related to some CHF complications. 4 were sent to a skilled nursing facility after rehab, and that's usually due to extended type of physical therapy treatment where they had no progression within our program. We have, like
Can I ask you before you go on? Sorry, I don't mean to interrupt. What is this? How many patients are we serving compared to what the capacity is in the medical rehab unit?
What you mean, our occupancy?
Is our occupancy at full?
Sure, our occupancy, we have 12 operational beds and 15 beds on the unit. With the acuity of the population that we serve, we've got to keep in mind our staffing, our nursing, our medical care. It is a 24/7 hospital. The type of care that we provide is somewhat higher than nursing care, skilled nursing and long-term care. So of course, and you'll see in other slides, some of our challenges have been recruitment, hiring, contract services for agency staff, which can affect optimization for bed capacity.
Okay.
But going back, we've seen a number of increasing unfunded, undocumented patients to this program the last 9 months. But however, we're still primarily treating patients with Medicare. The functional status improvement scores are still ranking within the 99% or 75th percentile for independent rehab facilities. And that's in comparison to 922 around the nation. Our therapy hours this quarter versus last year are higher. This is due to some complex ortho cases, some extended stays, and that difficult disposition. So this is our chemical dependency unit. It continues to grow. We've been actively treating the region and the community with our 3 service lines. Our inpatient medical detox, so far we serviced 74 patients this quarter for a total of 192 the past 9 months. This is a significant increase to our occupancy and program versus this time last year, which was below 140, about 140. Our goal is just to ensure that patients are discharged and reporting for aftercare appointments, that they're transitioning to a lower level of care, such as our 28-day program or into our IOP. They can have a PCP or another behavioral health agency that's following their care. Our goal is again to ensure that they're moving into that next lower level of care. We had 1 patient this quarter that was transferred to a higher level of care in our residential treatment center. That was due to some GI issues and complications that started happening. Our IOP program is averaging about 33 clients, which remains consistent at max occupancy for the 2 tracks that we're currently offering. We had 6 graduates again this quarter. That means 101 total clients have been served this quarter. IOP hours, they did drop slightly due to some class cancellations for some inclement weather that occurred in February and March. However, I anticipate that these numbers, or the number of IOP hours, will remain back up higher and consistent. Statistics for inpatient rehab, this again is significantly increasing within the last 9 months since we reopened it in July of 18. So far, we serviced a total of 51 clients this quarter with 31 graduates. We're communicating with HSD for certifying New Mexico Rehab Center. It's an inpatient residential treatment center for the 3.5 medically monitored care. We're discussing certification options for programming there to add to our licensing and accreditation. So some positive accomplishments this quarter by our chemical dependency counseling staff include all of them have been trained and obtained the ASAM certification. They've gone through HIV, STD, Hep C training and are certified testers. They've attended our Seeking Safety for the trauma-informed care, all of which are really essential to the evidence-based type programming and the services that we're delivering for the care of the patients. Our counseling staff, on a positive note, have tremendously helped facilitate, set up this experiential site internship for Eastern New Mexico University, our local university there. For student interns in our human services program as well as our social work program. They're facilitating group meetings as well as we have 6 PTOTAs students who are facilitating exercise and recreational activities within our 28-day program. So really positive accomplishments for them. We have 3 IOP graduates that are in the process of becoming volunteer peer mentors, and 6 of our past IOP graduates from previous quarter that have reported sober and doing well. So accounts receivable, we are working on our revenue cycle management. Again, our efforts are concentrated with our MCOs around the prior auths, insurance verification, utilization review, and working those claims or denials and those rejections. This quarter, we did collect about $753,000 with the potential to obtain more collections. Again, our efforts are really to bill timely, accurately, with that as a priority coming to the end of this fiscal year. Our MCOs, like Shauna had mentioned, have been working with us much better and for faster reimbursement as well. There's still some education as far as what type of provider type and billing type ASAM criteria that we follow within our hospital. That just has to be educated, re-educated, and told for them. But again, they are working with us closely. They're working with us better. I see that. This quarter, we're slightly below last year's figures, although we billed out more. One of our challenges this year has been hiring a financial billing specialist. We were successful in hiring a financial billing specialist to our team last month. So by the end of this next quarter, we hope to have a significantly higher rate there. So capital projects, we've got a lot going on in Roswell the past 3 months. We're currently working with Denise Berdine and George Morgan on 4 important capital projects to our facility. It includes our security camera system. Next one. Includes our security camera systems, our badge access swipe system, our front and back door entrance exit doors, including our fire dampers. The vendor for our camera badge systems way ahead of schedule. Currently, they reported that final testing and inspection will be next week. A second vendor has started on installing the front doors on our main entrance of the facility as of yesterday. And we're currently looking about a 10-day completion timeframe, George. Our fire dampers, they'll also be worked on. They're going to be brought up to code. There's 4 of them that need to be brought to code. That will start on the first week of May. Again, that's about a week we're looking as far as project completion timeframe. We're going to reconvene next Tuesday with Denise Berdine and some of their project managers with all 3 of them to review where they're at in their phases of work, inspection, tests, and any additional items that present to our facility. Contract cost utilization, and this just to follow up again where your question was asked in the beginning. Our total contract cost is higher and currently about $1.1 million this year. We had to recently add more funds to our main direct care support contracts, which are fusion and quick response staffing, due to the difficulty in hiring those FTE positions, which again increases the utilization of agency staff to support our operational needs. The direct care contracts are around PT, OT, speech, as well as registered nurses. Those are our main needs. We recently held a rapid hire in Roswell April 10th. We had no success in hiring registered nurses, licensed counseling staff, licensed PT and OT staff. Those are our high needs. We did, however, hire 2 PT aides and 1 nurse tech, which is currently in process with SPO. But we're still, we're still monitoring the utilization of our contracts and making necessary adjustments and changes as needed with our facility. So license and accreditation, we're still Joint Commission accredited for another 3 years. 2021 is when our next accreditation is up. We're not in the window yet. We are CMS deemed status hospital currently. We have IOP, which is that VHA 432 site for program. In fact, our annual survey is coming up pretty soon here in May and June for HSD to come visit us. Like I stated earlier, we're seeking certification through HSD for our 28-day residential treatment center. We have meetings coming up next week on Wednesday to discuss with HSD and others who are other facilities who want to receive the same type of accreditation. Quality, performance improvement. These are the top 7 quality performance areas that we're concentrated on. We continue to monitor and review our ASAM treatment plan for our residential program. Our certified ASAM counselors and clinical supervisor are reviewing and discussing treatment plans weekly as a team, as well as with the patient, to make sure that the goals, objectives, the patients are completing. There's measurable goals, measurable treatment plans within those areas. So our goal right now, our compliance is about 98%. And our medication errors, they've reduced dramatically this quarter with continuing monitoring, the training, some workflow enhancements that we made. There were no Class D indications this quarter. As you all are aware, there's been some new anticoagulation therapy national patient safety goals that go into effect July 1. We're currently reviewing our current practices, our anticoagulation selection, med management, care management, to comply with Joint Commission to increase, again, the patient safety for our medical rehab unit. Our medication reconciliation efforts in programming are trending above the 95% threshold. Again, we're focusing on pain assessments for the pre, post, and identifying and addressing where we could educate the patient on alternative type pain therapies. And that is, again, above 95%. Handoff communication still continues to be a little bit of a challenge. Of course, that comes with the utilization of contract agencies there. And so we're still having efforts to improve and require education for all contract staff that come to our facility. Some functional improvement measure scores, as stated earlier, for our FIMs. We are working on improving throughout the length of stay on patients' documentation to just consistently and accurately, and really to understand why it's important to state the correct functional status scores for those patients. As you know, it affects our national benchmarks as well. That's part of the PDCA that we got currently going with our Joint Commission efforts. Patient survey satisfaction. It was somewhat lower on MRU this quarter. It was identified in our surveys. It was discussed with our leadership team what we could do to remedy some issues and concerns. This was brought up due to some loud noises in the halls due to their construction and the closing and opening of doors. Kind of expected that and anticipated that would be a little bit of an issue, but we found some remedies to help satisfy the patients who are on our medical rehab unit. On all other departments, we're above the 90% satisfaction threshold. Human resources, we've had some staff turnover, retirements this quarter. We're currently averaging about 17% vacancy rate, with most of our vacancies as stated in our direct care arena, which again has increased our utilization of direct care contracts. Our HR director resigned in March, but we have selected a new HR director, which starts on Monday. So after she gets acclimated, we plan to hold an individual rapid hire at NMRC for those direct care spots. But I want to thank Tammy for letting us borrow Kathy Lucero in this interim. Some needs and challenges on our next slide. Has been, again, direct care staff, licensed OTs, PTs, registered nurses, licensed social workers, those licensed substance abuse counselors like our LADACs and LASAs. Again, in Roswell, there's not much within that arena to choose from, but we're doing all we can do as far as rapid hire events, making sure at those community events we're marketing our positions, we're talking to people, trying to get those qualified individuals into our programs. We continue to work with the 5th Judicial District or with the Adult Drug Program. We're looking to be certified in Chavez County sometime in July. This is going to be a huge essential to our 3rd track IOP for Chavez County. We've been meeting with our local hospitals, Artesia Hospital, Lovelace, and Eastern, to again educate, re-educate, to discuss our admission processes for inpatient medical rehab as well as our medical detox. Our counselors attended a yearly event at Villa de Esperanzas. This is another residential treatment center there in Carlsbad, New Mexico, to show some support and thanks for the referrals that we both share, collaboration again within the region. They have a residential treatment, however, they need that medical detox for their patients. So we've been working in collaboration hand in hand to detox them and send them to their residential treatment. So that's been an effective relationship there. We've been working with our local university, Eastern New Mexico University, again as a internship training site for social workers, human services, and OT aides. They have been valuable and we thank them. The mayor holds regular meetings with local hospitals, physicians, clinics, and businesses, which we're a part of. Right now, we're discussing physician recruitment, other specialists to Roswell. Everyone in the organization is working as a whole to help be part of a new orientation to any physician or any specialist that arrives in the community to go and meet with different hospitals, NMRC, Loveless, Eastern, other physicians within the community, to let them know that they're not alone, that they have a better understanding of what resources they have within our community to hopefully to attract them and retain them into our community. We will be participating in a summer event with some UNM students for the BAMD program, the ClinEd and Physicians Assistants in June. This will be hosted by our Mayor Solutions Committee, which we will be a part of. So our successes this quarter, begin positive and building stronger relationships with our local hospitals, parole, probation, the judicial districts, the community, and those involving ourselves in those local events coming up. Our NMRC Foundation, along with other key stakeholders, are sponsoring a large community health expo in Chaves County with the tentative date set on August 3rd. We will be a part of that event. This will include many hospitals, vendors, MCOs, physicians, clinics, to let the community know and the region know how wonderful the services that we have within our community base to hopefully attract more, keep more healthcare within our region. So there'll be a 5K run, 10K run, other activities, other vendor selections. The plans and preparation are underway. We should have an update sometime in July by next governing board on what the logistics are to that meeting. However, again, we still remain with our drug court marketings, our outpatient physical therapy and occupational therapy plans going into next fiscal year on that outpatient goal. Again, it's highly dependent again on our PT and OT finding those right permanent FTEs, but it still is on our radar, and we still plan to utilize that coming up next fiscal year. But that's it for NMRC. Any questions?
Are there no questions or comments? I have a question. The IOP 6 graduated in the first quarter. What's the durability of them successfully not restarting their substance abuse in a year?
We don't. We've been collecting it for the past 6 months. Again, that's true. Watching them where they transition, where they head out to within that lower level of care. The hard part, I think, the challenge for us is when we call, some numbers change, their demographics change, and they seem to fall off our radar. So those that we were able to contact and those that who contact us after the fact to report this, that's where our data lies. But it is.
You said 2 of the graduates are actually going to assist in
peer group mentorship.
Peer groups, so I assume those.
Yeah, so they've gone through our detox, our residential treatment, as well as the IOP group, and they plan.
And then I have one last question. Inpatient social rehab. What's an example of somebody what's a diagnosis that somebody's in there for?
So they're disorders. So again, detox is more of a like opiate withdrawal.
I got that. Inpatient social rehab too, right? That's
yeah,
one of
well,
your service lines.
Inpatient social rehab residential treatment, they're the same. Again, it's all around disorders. It's not withdrawals or more disorders. So it's a lower level of acuity for the management of their conditions. Although they come with some complex medical conditions, hypertension, anxiety, the depressions, those things that still require safe hospital treatment. Within that 28-day structure. So that's it's mainly disorders, this diagnosis that they're admitted on our opiate disorders, cannabis disorders, meth, cocaine, our regular substances.
Great, thank you. Are there any other questions or comments? with that, we'll move on to Sequoia Adolescent Treatment Center with Carmela Sandoval, please. Thank you.
Okay. We'll go on to our first slide. We are a 36-bed residential treatment center providing care for all male residents between the ages of 13 to 17 with a history of violence and mental health diagnosis and are amenable to treatment. You'll see our graph where our average census this quarter was 25. And our new admissions, we had 9. The highest new admissions were now in March. Our current census as of today is 27. We recently had our survey for licensing and certification, in which we received 0 deficiencies in our licensing survey. And that's around the area of nursing, medical, the environment, incident reporting process, policies, the vehicles that are used to transport our residents, and our training records. We are awaiting our certification report, in which we do expect to have a couple of deficiencies around treatment planning and discharge planning. But we did get an extension until the end of June, so we're expecting our certification report around that time. Our Sequoia projects, we need our fire sprinkler raiser and air compressor. We need that replaced. Our emergency generator will need a replacement of our fuel pump, and all these are in process. Our maintenance department, like Shauna said, has been helping other sister facilities like our public health office in Estancia, and will be providing our entire department support for Turquoise Lodge in their move, as that's going to be a big move. Our financials, we continue to meet with ASD monthly to make sure we're utilizing our best budget strategies and balancing our budget. We're gradually working on increasing our census. We're expecting to receive 58,000 from our National School Lunch Program. We do have a 90% collection rate. We continually to work actively with our MCOs. Our cost savings opportunities this quarter is that we were able to split our costs with our food vendor for repairs in our kitchen. That's the first, so that was a success. We did get a grant through our education department, and they're providing funding for our residents who are employed through the facility. It's a SWEET program, so they're paying our residents for that instead of Sequoia. So that's actually a success also, and some cost savings. Move on to our human resources. This has been our biggest challenge for Sequoia is our vacancies. We currently have approximately 45 vacancies, and they're, for the most part, all direct care staff. We recently hired our art therapist, which had been vacant for a while. We did have a rapid hire where we focused on techs and tech supervisors. We do have some vacancies in the nursing department. However, we do currently have, out of the 9 positions, we have 3 DOH nurses. Out of the 16 individuals that attended our rapid hire, we were able to successfully hire, or 4 individuals that were able to go through the end of the process with all the clearances and reference checks. So listening to Jose, I think that was, I was like feeling a little bit, that wasn't a good success. However, and listening to Jose, I think 4 was better than none. So we're excited about that. They're already on the floor and they're already working. So we also have, which offsets our vacancy, is we have a PRN pool, and we've been able to hire into our PRN pool, and so they're covering the vacant positions. And a lot of our PRNs have been there more than a year. So they're dedicated, they're considered core staff, they're very familiar in working with the residents at our facility. We continue, we no longer, the other thing that we did is that we no longer share an HR position with Turquoise. We were able to hire our own HR director, and she's in the process of transitioning and learning the ins and outs of a facility, a 24-hour facility. We continue to identify training opportunities for our staff. Our school psychologist provided training for all our staff at our general staff on executive functioning skills and strategies to manage them. We also focused, we identified through our incident management process is that sometimes our staff engage in power struggles with our residents, so we focused on that training, as well as how to separate a fight without initiating a restraint. As you're all aware, Sequoia no longer, and has not for the last 4 or 5 years, used mechanical restraints. Very proud of that. And we rarely use seclusion. So we really focus on teaching our staff de-escalation techniques and ways to avoid it. What we've seen is that for the majority of the time when we have to place our hands on these residents is when they're fighting with each other. And that's pretty much the majority of the time in our incidents. We go down to our performance measure data. You'll see that our average hold is about 6 minutes. We did have a high number of restraints considerably for Sequoia, with 16 in February. We did have a resident at that time that was a little bit challenging to our staff, and where he was continually turning on the fire alarm and focusing on safety things. So that's what contributed to our holds on the resident. Successful discharges, you'll see that in March was our highest. We had 100% of our discharges were considered successful. January and February, we had 1 that was unsuccessful. And for the most part, those that are considered unsuccessful are the ones that have had a probation violation and where their JPO has violated them because they're not successfully completing the treatment in the facility. Sequoia will be hosting a trauma-informed webinar for anybody that wants to attend, April 25th, and there is CEUs that are offered for those that require that, and the cost for that is $50. If you do not want CEUs, you're more than welcome to attend, and it'll be free. The Sequoia teachers, the clinical director, and the administrator will be attending our trauma-informed conference in June. And so we look forward to that, and where we're going to focus on our education department and how they can become a trauma-informed school and incorporate those techniques into the school day. The next slides are some highlights for Sequoia. We do test all our kids when they come in to the facility, and we test them post. And you'll notice from the slides that in our math, 89% of our students exhibited gains in math. You'll see that only 2 students were right even or 1 dropped. So that's really great for Sequoia. In spelling, we had 90% of our students exhibited gains in spelling. And sentence comprehension, we had 100% of our residents showed gains. And then last was our testing and word reading, and we had 89% of our students exhibit some gains. So that's really exciting for Sequoia, where we're really focusing, along with our therapies that we do, we also focus on the education. In this reporting period, we had 1 student complete his HiSET exam, and 1 currently enrolled this week to take his GED before he discharges. Any questions?
I have a question. Your PRN tool, Carmela, is that strictly for nurses, or are you using techs?
No, just techs. I don't have a PRN tool for nurses.
Okay, because I want to work on that. I had asked about it, so I have them for nurses, but not for techs. So that's good to know.
Yes.
Follow up on that. Thank you.
And Kathy Lucero, she's very knowledgeable. That was something that was in place prior to me coming to, but she was very familiar on how the development and how we were able to get those positions and how they work.
Yeah, we tried and weren't successful, so we'll get back with Teresa.
And it's only a year, from year to year, there has to have a break in service.
So it's different for the nurses.
And they don't get no benefits. You're welcome.
And the other question, I'm sorry, how do we sign up for the webinar?
Just give me a call, and then we need a call because we need to make sure we know where we're going to set it up for Chris and how the size of the room. But just send me an email.
We can send people.
Absolutely, absolutely. It's already paid for, and it's from 7 to 3 with an hour break.
Are there any other questions? No. With that, we will move to New Mexico Behavioral Health Institute. And perfect.
Thank you.
Thank you.
NMDOH has 5 distinct divisions, and today I did want to talk a little bit more about each of those divisions. So the next slide will start with the adult psychiatric division. We do have the only publicly funded state psychiatric hospital in New Mexico. We have 2 admission units and 4 extended care units. We have 121 licensed beds, 96 operational beds, and there is some legal and clinical criteria for admission. And our average length of stay on our admission units is 14 days. Next slide is about our forensic division. It is hospital-based setting. It's licensed and accredited as a specialty hospital. The same as APD, has 116 licensed beds, and about 40 to 50% of our patients have been found to be non-competent and non-restorable. And our services include treatment to competency to stand trial. Admissions come from throughout the state, different counties throughout New Mexico, and they're sent to the forensic division for court order services due to an alleged felony level of crime and are needed treatment to attain competency to proceed with adjudication. CARE stands for Center for Adolescent Relationship Exploration. It's a specialty residential treatment center, and it's licensed by CYFD as an accredited residential treatment program. It's accredited by the Joint Commission under the Behavioral Health Standards. It's licensed for 20 beds and has 12 operational beds. And we provide care for treatment for adolescents 13 to 17 years old, only males who have caused sexual harm, and they also have to have a mental health diagnosis. The long-term care unit, also known as Meadows Home, has 4 neighborhoods currently: Evergreen, Juniper, Aspen, and Ponderosa, licensed for 176 beds, and we have 163 operational beds. We provide low NF, high NF, and skilled nursing services to the people who live here. The focus is on person-centered care, and we're one of the first 5 facilities in New Mexico to be certified as restraint-free. And phase 3 of our new construction began in March. Finally got phase 3 started. And our last division is community-based services. That's our outpatient program. And we serve approximately 1,100 clients, and we serve 3 counties: San Miguel, Mora, and Guadalupe counties. We're recognized in the state of New Mexico as a certified community mental health center and a core service agency with a designated targeted population diagnosed with severe mental illness and chronic substance abuse. The next slide is our average daily census by division. Our APD unit averaged 81 patients this quarter, forensic 49, care 5, long-term care 125, for facility total of 260. Our outpatient program currently is servicing about 938 outpatients. We have seen a decline from last quarter. Psychiatry saw 907, psychotherapy 131. Our CCSS program has 20, and our psychosocial has 28. Next slide is on Joint Commission licensing. Our triennial survey occurred in August 15th and 18th of 2017, and we were cited, like every other hospital, psychiatric hospital in the United States, for ligature risks throughout APD. Our initial repair cost was $1.2 million, and that's to our units within the adult psychiatric division. And during the return visit on August 24th of 2018, we had additional findings in common areas. And the reason for that is because we were one of the first hospitals to get surveyed under the new ligature risk standards. And in the meantime, between our initial visit and our follow-up visit, they expanded it to the common areas, hallways, rooms for people dying, staffing rooms. So that cost us an additional $338,000 to repair those areas. A third visit was required to clear our doorknobs for the seclusion rooms, and finally we were cleared on March 19th of this year. So it took us a long time to become fully accredited, but we're finally there. We are continuing to work on some other areas that I'll talk about when we get to our capital project. And our care survey is due by June of this year for licensing. And our window's open for long-term care. I think they came last March, right? So they're already a little bit past due for long-term care. So hopefully they can show up today, and they didn't. And then our budget information, we don't segregate our budget by service line. Our general fund is 30 million. Total projected other revenues for this fiscal year is 27 million. And our total operating budget's about 58. Our projected uncompensated care for the quarter is 5.7 million. Our total contract cost for the quarter is projected to be a little bit over 1 million. Our second quarter collection rate is still not at 90%, which is our goal. We're still about 88%. We've had a lot of vacancies in our billing department. We finally were able to hire a data processing supervisor, and we're pending approval for a reimbursement supervisor. And we have one insurance follow-up clerk vacant. We're also working on trying to get another biller so that we can get our collection rate up. Capital projects, this is where we have a lot of fun because we're such a big old facility. We are redesigning our nurses stations, and that's part of the ligature project because there are some, at our APD, patients can enter the nurses station. So we almost got cited and we didn't because we always have somebody in attendance at the nurses station, but they highly recommended that we needed to close them because you can never really guarantee that there's always going to be somebody standing at the nurses station. So we're working on that. We could continue to work on roof replacements, and we did have a meeting yesterday where we did get some funding approved for 2 more roofs. Our Meadows Phase 3 I mentioned is in process, and our completion date is July 2020. That's our anticipated date to complete Phase 3. And at that time, we will be able to house all of our residents in the new facility. Our APD HVAC project is a major project that is scheduled to begin sometime in May. I think we're predicting it'll be mid-May. And this project is going to take 400 days, which when I got that news, I almost fell out of my chair. I was like, oh no, what that means is that when Joint Commission returns in August of next year, we might still be in the middle of this project. It's going to be in 4 phases, so we're going to have to relocate patients from our 6 units that we have within APD from one unit to another during the phases. So it's going to be a challenge, but we're getting ready to start that mid-May, hopefully. We have an asbestos abatement project at ZIA that's almost in process. That's where we house our adolescents. We did have to relocate them to another building during the abatement and flooring project, and we're anticipating that'll be done, I believe, next week. And then we'll have to just get CYFD to come in and clean the building, and then we'll move the kids back into that building. Life safety drawings for patient care areas is a process that was finding during our last survey. We were able to come up with some drawings that we had to hand draw to show where different areas were, but we have a contract that we're working on with FNP to work on the life safety drawings as well as the APD ADA compliance assessment that we need to get done before our next survey. And then La Planta, which is the building that has our maintenance workers, is structurally unsound, we found out during our fire marshal inspection. So we're working on that. When I did my PowerPoint, it was pending funding, but we did get some funding through Capital by George. Thank you, George, for all of these projects. And that's going to be starting soon. Next slide, our human resource information. Our direct vacancy rate is at direct care vacancy rate is at 31%. I have a breakdown of how many people we hired and how many separations we had. And we once again had a net gain of 1. So we're still struggling to get positions hired, but we are making some progress. The next slide talks about our recruitment and retention performance improvement team. It continues to meet. We did have a rapid hire on February 4th, where we hired 18 techs and 2 nurses. We had another one on April Fool's Day, which I didn't think was a good day, but we did okay. We initially thought we were going to bring in 12 techs and 2 nurses. That went down to 10 techs and 1 nurse by the time they go through the background check, the selection process. So we did do well. We're going to continue to do those every other month. Our advertising continues in our local Sunday paper, LinkedIn, Facebook, and Craigslist. And our team is really focusing now on retaining staff. I think we're doing a better job of recruiting than retaining. Our staffing ratios, we've revisited those throughout the facility. We do that at least on a monthly basis. So we decreased the number of staff required to take care of our patients throughout our 16 units in the hospital. We have an ongoing interview process that we've implemented. During our meetings, we review those because every new nursing employee gets a face-to-face meeting with the nurse manager at 30 days, 60 days, and 90 days, and we review the results of those to see why are people leaving, what can we do to keep them here. And we are hiring part-time techs, and we're closely monitoring all our level 1-to-1s, try to get those discontinued as soon as possible. And we're also allowing our techs on mandatory overtime to leave early whenever possible. So people that are being mandated from nights to days, we try to let them go at the 4-hour mark, so they're only working 12 hours instead of 60. That's been very successful. What are our patients saying about us? This is an example of some of the questions that we ask our patients. Majority of them come to our adult psych. Anytime a patient's discharged, our patient advocate meets with them, goes over the questions, and you can see that we're well above our 90% even on our food, so we are doing all very well. Our training initiatives, we did have LBG QT training on March 20th. That was sponsored by OPA, and we had 57 employees attend. 2019 Leadership Symposium was held in February, sponsored by NMHCA, and we had Susie, our long-term care DON and accreditation officer, attended. 2019 New Mexico Partners in Preparedness, Safety Director and Safety Coordinator attended that. That was sponsored by Department of Health. Our Cultural Competency training sponsored by Highlands University. We had 4 social workers attend, and they also attended a recruitment fair for social workers. And then our care unit receives CPI training every 6 months. Community outreach, we did have a visit from Ken Ortiz, our GSD secretary, Anna Silva, interim FMD director, Senator Pete Campos toured our facility, and that was coordinated by George, and George was present. I thought it was a very good meeting. They also looked at a vacant building that's across the street from our facility during that time. Our care residents continue to volunteer at our local soup kitchen weekly. Our social workers and PR coordinator attended the social work recruitment fair at Highlands in March. Our CBS division director attended the Guadalupe County Behavioral Crisis Task Force meeting. Long-term care activities employees have seen an increase in volunteers, so that's really good. And our Luna Community College Cosmetology Department offers free haircuts to our outpatient clients. I wanted to talk a little bit about some of the activities we did in the last quarter for our patients within the adult psychiatric division. They had dances for Valentine's Day and St. Patrick's Day. They had movies, bingos. Patients planted seeds that will be started plants for the farm. We have a farm on our campus, and we have a greenhouse. So in March, patients who participated in the work program prepare the greenhouse beds in preparation for planting season. So that's really fun because they get to go outdoors and do that. At Forensic, they had bingo, dominoes, ping pong, horseshoes, frisbee. They created these monthly calendars for activities, and they also had tournaments this quarter with prizes for the patients. Long-term care, they celebrated New Year's, and during that celebration, they reminisced about years past and had New Year's resolution discussion, Valentine's Day dance, and they had a St. Patrick's Day party. Care, the Santa Fe Mountain Center continues to provide experiential therapy to the residents every Tuesday. The United World College provides activities to the residents every Monday afternoon. During the quarter, the care residents participated in therapeutic outings, so they went to Dairy Queen, Rialto, they did a scenic drive to Mora, got to go visit Teresa's, world famous, and then they go to Walmart to practice their budgeting. Outpatient activities. In January, the clients attended the Taco Bell luncheon. In February, they had a Valentine's Day celebration. They had a Valentine's Pong Challenge bowling. And in March, for St. Patrick's Day, they had a ping pong race and a team relay contest. And they went to the side for lunch. And that's my presentation. Are there any questions?
Yes, so my question is about the long-term care at Meadows Home and the phase 3 of Meadows. Got 163 operational beds, 176 licensed currently, and the census right now is, average census was 125. My concern is on phase 3, is it feasible? I mean, are we gonna fill those beds if we build it? Are we gonna be able to staff it?
Yeah, we are. I mean, currently our census has been down because of our staffing levels. We've had some referrals, and our goal is to get back up there. We were running 157 last year, and our goal is to get back up there once we're able to recruit and retain more staff. And that's our current census, right? We currently have 163 occupation beds. That's what we currently have.
Right.
And phase 3 is going to give us that same number, I believe.
Yes.
Because we've got
That's
3
54.
wings, yeah.
So
We're adding 54 beds. So we currently have patients that are not in the new building, they're in the Ponderosa building. So this is going to get us out of the old building and get our current residents into the new building.
okay,
And we are confident that we'll get back there. We just need to rebuild our
we'll
staffing
get
levels.
to that point.
Because last year, our
How old is the Ponderosa building?
How old is it? It's in the early 1900s of 1800s. These are old, 1889, that one.
So
So
it's
we
not
really-
an increase in number of beds.
No, it's really to house our patients. As a matter of fact, for the phase 1, years ago, what year was it? 2005, I believe, we had a joint commission survey, and our Meadows building was so old that they almost didn't accredit us. So that's when we really started planning on what do we need to do. So they demolished the old Meadows building, and that's where phase 1 came into, and then phase 2, we were able to move the patients from Ponderosa into upstairs. And our phase 3 will get all our residents into the hospital facility. And it's beautiful.
Yeah, if you recall, initially we were looking at 72 beds. And
We've reduced it.
we reduced it to 54, correct?
Are we still doing the phased in version of that? Like it's gonna start with 32 and then if we need to build out more, we're going to, or is that
Starts with, 36.
36, sorry?
We received the additional funding through this legislative session, so we'll move forward with the 54.
We're doing the 54 straight right away?
Well, we need to wait till the bonds are sold.
Okay.
This last appropriation through the legislative session, which will be sold in June or July.
Okay.
So we'll probably do a contract change order come August time.
I guess that sort of leads into my next question, and I was kind of holding off until you, because you have the most employees, but you know, we did that salary adjustment last year, and it was a pretty sizable salary adjustment. I mean, what's the feeling as far as recruitment and retention?
And you're talking about for the nurses?
For the nurses, yeah.
We used to have 28 vacancies. Today I have 11. It's been really, really helpful. And it's a wonderful thing to do because we're actually, I know with our local hospital, we've even recruited nurses from there. So they're in more trouble than we are. So we're not having any trouble recruiting nurses.
It's improving, and you think it's going to continue to improve?
Yes, I think that eventually we're going to have a waiting list for nurses. And I think we're getting there very quickly. Now, we just need to do that for the techs. I mean, that's where we're struggling with the techs. And I do believe that we are working on appropriate placement for the techs.
That's what's happening now.
Right, we're working on appropriate placement, and I think that that'll make a big difference for the techs.
Psych techs and nurse techs, correct?
Yeah, CNAs, psych techs.
Is there anything in the works for OT and PT? I mean, that's kind of you brought that up as an issue for you.
Well, we did have the healthcare study that was sponsored by SPO. And
Still not complete though, is it?
right, it's not complete. The goal is to get it complete by the end of June, beginning of July. We've been in communication with that study. It's in the final phase, so we're waiting to hear. We're confident that that's really going to help us.
Thank you.
Thank you, that's excellent. Any other questions? No, and lastly, we have Las Lindas Community Program and Tammy Alikar will present. Thank you, Tammy.
All right, Las Lindas Community Program services that we do provide are supported living, crisis residential, customized community supports, which is also called rehabilitation, community integrated employment, and that's provided by Valley Employment Services, and so we nicknamed that VES. And then we do have an intermediate care facility for individuals with intellectual disabilities, and that's our ICF. Our current census for the program, supported living, we have 57. Crisis residential, we have 1. For Dayhab, we have 61. For VES, we have 23. And in our ICF, we came out of a 6-month zero census, and we now have 1 person as of 3/29. And our Jackson class members, we have 34. For licensure and accreditation, our ICF services, We did get our inspection in March and we received our report last week. And there were 3 findings, and we will get that report submitted by tomorrow. DD waiver services, there were no QMB activities this quarter. IQR review, 7 of the 8 reports were closed within 90 days, and the last one did finally close 2 weeks ago. Final report for individual, and that was the final report, that only receives inclusion services from LLCP, and the case manager was able to get that one closed. Financial updates for the quarter, the billed was $1,809,000, and our collected was $1,859,000. Our facility projects, we're improving exterior lighting, the roadway, parking, and sidewalks to better meet the safety needs of the campus. We're renovating the campus entry guard shack building to support developing a campus consumer greeter program. And we are continuing our campus beautification project. For our human resources updates, we have a total of 295 FTEs. We currently have 234 positions filled, bringing our vacancy rate for the facility to 23.05%, and for our direct care staff down to 22.69%. Currently 6 on workers' comp and 19 out on family medical leave. We did have 2 rapid hires during the quarter, one at the end of January. We had 35 persons attend, 27 received and accepted contingent offers of employment, 23 started NEO, and we have managed to retain all 23. In March, we had 18 persons attend, 14 received and accepted contingent offers, and 8 were able to start. We do have a couple more that are coming in later. They have to give notice at their current positions. Our performance measures from the Smart Sheet data, our elopements, we did have 1 in March, and our last one was last year in August. So we'll continue to monitor that. Medication errors, there's no trend identified, so we will continue to monitor those. We haven't had any significant medication errors. Most of the medication errors are giving PM meds in the AM or missing a dose, and so those staff do receive remedial training. Falls reporting, there's no real trend with the falls, so we will continue to monitor that. A&E allegations, no real trend, so we will continue to monitor that, and we are receiving closures to several of the investigations from last year. Any questions?
No questions or comments?
Excellent rapid hire.
Yeah, that was good.
All right, I move for an approval of facility administrator reports.
I can make that motion.
Great, is there a second?
Second.
Any discussion, commentary? We'll take a vote. Approval of facility administrator reports. I'll say aye.
Aye.
Aye. We'll move on to program area 6 financial reports. Is Charles Harmon going to call in?
No, he's not.
So who's going to do this? Great, George, welcome.
All righty. Facilities Management Division Financial Report. This is for period ending March 31, 2019. At this point in time, we have a projected deficit of about 2.7 million total. You can see the actuals there, FY18, where we had a surplus of 2.1. Next slide, please. Facilities Management Division, the operational budgets, you'll see various funds there. General Fund, 55.5, Fort Berry Medical Center lease, the interagencies, for a total budget of about $127.8 million. On the following slides, you'll see the details of the budget. That's it. You write it once. You do. I do also. Okay. On the that sheet there, performance measures. This is for quarter October 2nd through December 2018. You'll see percent of eligible third-party revenue collected at all agency facilities. Our target 93%, actual 85.4. Number of significant medication errors per 100 patients, less than or equal to 2.0, we're at 1.0. Percent of long-term care residents experiencing one or more falls with major injury, less than 0.5%, we are at 3.9%. So with that, I can stand for questions.
Any questions?
I have just a question. Last quarter, we discussed briefly 0.5% on that last performance measure. Is that real? How are you going to get 0.5?
Well, remember we talked that it was legislated, right? So we can't change it. House Bill 2. Just gotta keep trying.
So we just have to continue to explain.
Do you mean that number is just too low to attain?
Oh, yeah.
Just some realistic.
It's not realistic.
What are our national averages?
Do we know what the national averages are? Todd, you-
Not target,
I don't right off the hand.
No, but that changed from last year, it was 3%, down to 0.5.
So we're not sure
So
what.
we're not sure what happened with
Federal,
that target,
federal target,
state target.
State during legislative session.
Good luck to investigate that one, right? Any other questions or comments? All right, I think the next section, Dr. Novak, are you on the line? Oh, sorry.
We need to do an approval
Oh.
of the finance.
Oh, I apologize, I'm very new to this. We need to approve the financial reports. Is there a motion?
Motion. Carmella.
Carmella,
Second.
Carmella, in a second. Thank you. So approval of the financial reports, all in favor say aye.
Aye.
Aye, great, thank you. Dr. Novak with presentation of policies. Are you available?
Hi, yes.
Can we turn him up somehow?
Go ahead.
That's all the way up. Okay, Dr. Novak, you're gonna have to speak up. But you have the floor.
Hi there, everybody. Good morning. I'll try to make this quick. Actually, I haven't, this is only my second meeting. I haven't presented policies before. I think that these are NMDOH policies, and if I understand right, Francis?
Yeah, that's gonna be my PI plan after the policies. So I think what happened is we all had to submit our policies because our drive wasn't working. So I believe all of us reviewed everybody else's policies. I had some, Jose had some, Tammy, you had some. Shauna, Carmella, you didn't have any?
I didn't have that.
So I think we all reviewed them.
Okay, so then do we move to Francis? You talking about the NMDOH's PI plan?
Yeah, I just needed to get approval. I sent it out to everybody. It's a little summary of how we do our performance improvement.
Okay.
Talks about our mission, what our performance indicators are. And if you look at the last page, I don't think you all have it there, but basically what we do is every division, because we do have 5 distinct divisions, set up what their performance indicators are going to work on for this coming fiscal year. We also have some for administration. And what I'll do at the next meeting is I'll bring you the evaluations, not just for the performance improvement, but also for our other plans that we have, our emergency management plan, our fire plan. So just to approve our plan. Questions on it? I don't.
Any questions from the phone? Nothing here, President. All right. I don't think that has to be approved officially, though.
Yeah, it does. We do have to approve the policies and the PI plan.
Okay. Is there a motion to approve these policies?
So
I'll second. All in favor of approving the NMDOH PI policies?
Aye.
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 So approved. Dr. Christopher Novak, are you going to talk about presentation of credentialing?
Okay, I can do that.
Great, thank you, sir.
So the Medical Executive Committee met on Thursday, April 10th, and we reviewed it was our quarterly meeting, and we reviewed the credentialing and privileges. The packet does have a list of the providers by facility. There were, overall, there were no concerns for any of these providers. Would you like me to, if I could get a motion to approve these providers for credentialing and privileging, or would you like me to read through them individually?
I don't think we need to. Everybody has this in front of them, the credentialing list. So is there a motion to approve the credentialing report as it is reported to us here?
Motion.
Is there a second? Is there any discussion? All right, all those in favor of the credentialing list as presented by Dr. Novak, say aye.
Aye.
Aye. Aye. Okay, so approved. Continue on, Chris.
Yes, this will be my last meeting. Dr. Massaro will be taking over, I believe, as a Medical Executive Committee chair. So thank you, everybody.
Thank you, Dr. Novak.
Is there anything else, or can I hang up?
You're done forever, Dr. Novak. No, thank you for your service.
No. I'll see you all. I'm not going anywhere.
Dr. Novak.
Okay. Thank you, everybody.
Sorry. Yes.
Did we just approve her? No,
We approved all the policies that were reviewed by each of you.
Okay.
Correct?
Correct.
Correct. All right. Is that?
That was, yes.
Above board. Okay. With that, I'm going to actually hand it off to Melinda at this time. Melinda Walensky, talking about governing board bylaws, correct?
Yes.
Okay.
Thank you. So I prepared some proposed changes to the bylaws, primarily for the purpose of including the Veterans Hospital effective July 1st. And also to correct a typo I found, and to remove the chief nursing officer as a member of the board for budgetary considerations. I'm actually not sure the status of that. Have any of you heard further about any budget concerns about the chief nursing officer? We can always add the position back in if we remove it today. And so I guess it's, I am a non-voting member of the board, and I recommend that the bylaws be amended as I have proposed, but I can't move.
Is there a motion? This is the only change to the bylaws that I read, correct?
Yes.
Removal of the chief.
Before you do that, can I ask a question?
Please, Eric. Should he ask?
Prior to veterans moving over to the Veterans Department, members of the Veterans Department sat on this board. Is that going to be included within this, when they come back? Is that going to be, are we going to have Veterans Department members here?
Yes.
Correct.
Yes.
Thank you.
So we included in the membership, and then they, effective July 1st, will become a voting member of the board.
Okay.
Any other questions? Any discussion around the amendments suggested by council?
I do have one.
Yes, please.
Melinda, I know I'm slated to talk after in the facilities meeting, but some of the leadership standards that have just been released by Joint Commission, I can see on page here, this committee, page, oh gosh, doesn't give it page 7 and 6 and 7. Some of those leadership standards on how we, the governing board and the medical director tie in and how they communicate to other medical directors within the facilities. And I'll speak more to it, but I think there's might be some verbiage additions that we can add in there if in fact that's going to be some roles and responsibilities that we go through with. But I can provide you with that information.
So you said there's no requirement for a chief nursing officer, right?
There's no chief
It's only at the facility level that has to be a chief nursing officer. Okay.
Absolutely, yeah.
So I
It's a
think-
new hospital status, since we all report up to the governing
Right.
board, it will impact us all as a group. And it's requiring that a medical director, somebody within the governing board, communicates to our medical directors within our facility to discuss inequality, performance issues, things of that nature, to bring forward into MEC or further up to our this type of forum. So there's just those additions, Melinda, that might need to be included.
Those are effective July 1.
July 1.
So we could.
Well, they were effective January 1.
January.
Right.
So we might have to look at that.
Sorry? Right, I'm trying to decide what to recommend. I guess I still recommend that we accept these bylaws, and I can prepare and provide all of you with a change, the proposed changes, and I guess Secretary Kunkel can decide whether or not to have an emergency meeting to accept those changes at a later date.
Yes. Do we just?
So based on that, I can make the motion
Okay.
with all the recommended changes to the bylaws.
Okay, is there a second for that motion?
A second.
And accepted in that form? All say aye. Aye. All right, announcements. Do we do announcements? Angela?
Announcement, I sent out an email invitation for our next governing board meeting to take place on Thursday, July 18th, I believe. Again, location to be determined, and I'll let you know, most likely it will be in Albuquerque. I'll let you go.
Next agenda item is open comments from the public. Is that correct? Are there any questions or comments from the public? Is there anybody on the line that would have any inquiries? No, with that, we'll adjourn to a closed executive session. We're ready? All right. We are going to reopen this to the public session. At this point, that's all we really need to do other than adjourn the full governing board session. Is that correct?
That is correct.
Is there a motion to adjourn?
Motion.
Is there a second?
Second.
All those that are in favor of this, say aye. Aye. This session is closed. Thank you.